Okay, so we are going to look at a lot of things on pediatric nursing. Okay. Pediatric nursing is very, very, very broad, but we will look at some salient points and some areas where we think it matters more on the end days. Okay. As and when things come up, adding them, we analyzing a lot of things. We'll be seeing a lot of things which are or which might not be on the slides. Okay, but they are also equally important as far as pediatric nursing is concerned. So we will begin with some pediatric disorders. Okay, then from there you will see what we have next. So the first thing to talk about is diabetes mellitus type 1. Okay, what is another name for type 1 diabetes mellitus? Yes, another name for it.
Juvenile diabetes, sorry.
Juvenile diabetes. So why do we think we call it juvenile diabetes? When you say something is juvenile, what does it mean?
Young.
Young. Okay. So when we talk about juvenile diabetes, what we mean by it is that um it's normally or you can find it among younger folks, okay? You can find it more among younger folks. So let me ask you a quick question before we even dive into it. Can an 80-year-old female get diabetes mellitus type 1? Hello? Are we here? Is it possible? A
So the
tricky
question
question, right?
again. The question again, I think.
So we are saying
The question again.
another name for type 1 diabetes mellitus is what? Juvenile diabetes.
Juvenile diabetes.
Yes, it's
Right, and I'm
possible.
asking a follow-up question. Can an 80-year-old male or female get diabetes type 1?
Yes.
No.
Yes.
Oh, really?
Yes, the fact that it's juvenile doesn't mean it can affect old.
Okay, okay, okay. Yes, so the short answer is yes. Okay,
Oh.
it's a tricky one. Yeah, so the short answer is yes, even though it has another name, which is juvenile diabetes, but anyone at all can get. All right, forgetting the fact that it occurs mostly among um, children doesn't mean if you are an older folk, you can get. And we have type 1 and type 2, right? Common ones. If you want to use the term diabetes, I think you can have about four different cases where you can even mention diabetes. One, talk about diabetes mellitus, okay, type 1. The second one, you can talk about diabetes mellitus type 2. The next one, you can talk about what? Gestational diabetes, which is another form of it. Then another condition where you can use the word diabetes is diabetes insipidus, right? Which is entirely very, very different from the other three forms of diabetes, right? Just know the differences among all of them. So over here is diabetes mellitus type 1. All right. Now, if we want to compare diabetes mellitus type 1, I want to pick it up from here so that you'll understand and appreciate what we are doing. Okay. Diabetes type 2 is mostly a metabolic disorder. Okay. But the type 1 is mainly autoimmune. Okay. So just take note. Type 1 diabetes mellitus tends to be an autoimmune disease. That is why anyone at all can get. So you know what autoimmune diseases are and how they occur, right? The body attacking or the immune system attacking its own cells, right? So this is what we have here. So um, when that happens, you have no insulin production. Okay.
No Salana. No catch yourself in town, no cut up until
Shafiu, I just muted you. You should turn off your microphone, okay? Unless you want to talk to us. All right. So yes. Okay. So the immune system attacks its own. I mean, it attacks your own body, and in this case, will drive your body or will lead to no insulin production in your body. Yeah. Okay. That is what I've made it very simple here. So, remember, insulin is always needed for your metabolic needs to be complete. All right. So if there is no insulin within you, what is going to happen? We have to get an external form of insulin. When you read about insulin, it's very interesting. Okay. I think it's now that mostly they prepare some in I mean through synthetic means, okay, in the lab. But I don't know whether it's still even is it's still happening. Okay, but long ago they were preparing insulin from animals like pigs. Okay, they were using. I mean, yeah. I mean, they were getting the insulin from pigs and some other big animals. If you read more about insulin, you especially the drug. Okay, but it passes through a nice harmless means, okay, or processes before it is being used. So let me ask you here, what is the function of insulin? What does insulin does? Who can help us so that we can expand our understanding here broadly. What's the function of insulin?
It breaks down carbohydrates to glucose, which does render it acceptable to absorb in the outstream in the body.
You're saying insulin breaks down carbohydrates.
Insulin acts.
Mm-hmm. I'm listening though.
Yes, it acts on carbohydrates
Okay.
and changes it to glucose,
Okay.
which is
Okay.
then absorbed in
Okay.
the body. Mhm.
Okay. Thank you. Thank you. And who else wants to try? Yeah,
Okay, Ross,
Francis,
I
your
would
hand
like
is
to
up.
also. Yeah.
Okay. Francis hand is up. Then after you can come in.
Okay. Okay, boss. What I know about insulin is it helps in the transfer of glucose from the blood into the body tissues.
Okay. Okay. So that is the exact point I wanted to hear. Okay. So just
Okay.
imagine you have hungry body cells, okay, and you have glucose, like it's like there is food. So let me give you an example. Let's say you have a toddler, let's say 3-year-old baby boy or girl, and that kid is very hungry. That kid can't feed him or herself, right? So you need someone to feed this baby. Even though there is food in the house and everything. Okay, there is food before That's very key. But that kid cannot eat unless someone helps him or her to. Okay. So when you, the mother, you put the food, okay, as you fetch or you breastfeed or you spoon feed your baby, that act is like you being the insulin. Okay. So the food is available, the baby is available, but the baby cannot eat without you. Okay, so that's how it is with respect to insulin. The body cells requires glucose, right? And as you eat, your digestive system will end up releasing glucose or making glucose available in the blood. Now, the glucose will have to be available, will have to enter into cells, okay, for the cells to utilize them. So it is the insulin that will make the um, that will make the glucose or that will carry the glucose into the body cells for them to be able to utilize them. Okay, so that's the function of insulin. That's why um, when it comes to especially diabetes type 1, its treatment modality is a bit different from um, from the type 2 diabetes, right? Apart from um, the juvenile diabetes, okay, being another name for type diabetes type 1. What's another name for diabetes type 1?
Insulin dependent.
Good, good. Okay. So another name is what? So when you see IDDM, okay, insulin dependent diabetes mellitus is the same as the diabetes type 1 we are talking about. So with this one, you have everything available, but you have glucose available, you have your cells are intact, but the cells cannot pick up what the glucose because insulin production. The cells, so it could be a lot of things happening, but mainly because there is no insulin. So when you have, let's say, your immune system attacking your pancreas, in this case, remember your pancreas is responsible for production of what insulin, right? That is the endocrine function of the pancreas. You know, I hope you know the endocrine function. It's like I don't want to go into deeper, but it's calling for it. You know the endocrine function of the pancreas, and you know the exocrine function of the pancreas. Do you understand those two statements? Endocrine glands
Yeah.
are glands, okay, that produces hormones or secretions directly into the blood without any duct, okay, without passing through that. So the pancreas has two functions, like it can exist as what? Endocrine and exocrine. Okay. The exocrine one is the production of what? Of digestive enzymes, which passes through the sphincter of Oddi and pours into the small intestine, right? That one, it's you have those digestive enzymes passing through that. And that same pancreas releases insulin, but it doesn't pass through any ducts. It releases directly into the blood. So that is the endocrine function of the pancreas too. So that is where our concentration is because we're talking about type 1 diabetes mellitus. So when this happens, okay, when you have um, the body's immune system destroying the pancreas, for instance, it is going to impede what insulin production. Okay, so in diabetes type 1 or insulin dependent diabetes mellitus, the main issue is that there is no insulin production. That is why people of such nature will require what? Daily insulin shots. Okay. All right. And the goal for this whole thing is to maintain what? Safe blood glucose levels. Right. So when remember, for some reason there is no insulin, or yes, let me say there's no insulin production, so the glucose level will have to stay high, because as you eat, I mean, there's nothing happening, or there's no fault with how your body changes complex carbohydrate to simple glucose. Okay, everything will happen fine, but the glucose will build up in your blood, and the body cells will be hungry. Okay, so you have more sugar, you have more food in abundance, but the body cells cannot eat them because insulin is not there to carry the glucose to the cells, okay, for them to eat. All right. Thank you for writing on my screen. So what's the priority? The priority thing when you're dealing with diabetes type 1. So child safety is a priority, remember. Okay, so we want to prevent hypoglycemia from happening. Okay, and as well as hyperglycemia too. So when the child is taking insulin shots, remember, we don't want hypoglycemia happening. Hypoglycemia can kill you faster than hyperglycemia. Okay, they can all cause serious damages, but hypoglycemia will kill you faster. All right. Then, as part of the priority or as part of our safety measures, we have to make sure that the child does not run into what? DKA. DKA, please, it's an emergency. Okay, it's a medical emergency when it comes to diabetes mellitus type 1. Okay, this is an emergency. So when you get priority or prioritization questions, compare with the options you have. If you have diabetes ketoacidosis, okay, diabetic ketoacidosis, don't think it's a general medical condition. That is what I want to tell you. If this is an emergency, it can, if care is not taken, it can lead to lots of things, multiple organ damage. So this is an emergency. Anyone with diabetes ketoacidosis is treated in the ICU. They are not even treated in, like, on the ward. Okay. Any question on this slide before we carry on? We are all much aware, okay, of diabetes type 1. This is not our first time of hearing, so I will just be mentioning those points where you have to pay attention to as regards to um, pediatric nursing in relation to the NCLEX, okay? So I'm not going to go into that detail, like we are doing everything afresh as if we don't know what diabetes type 1 means. Everyone here, I believe so, knows about diabetes type 1. After all, we are all nurses, right? So just to hammer on certain points, right? So that your eyes will shine when you get endless questions on that. Any question? Can we carry on? Okay. Now there's something we call sick day management. Who has seen this term in any endless question before, like any Q bank? Have you seen sick day management somewhere before? So here we are, sick day management. Okay. So sick day management. Take note of these points very, very well. These points are well summarized. They are in straightforward points, but you can be asked about 10 or 15 questions from this side alone. Okay, and we ask of several questions from this side alone. So what sick day means is that in terms of or in times of illness, okay, how do you manage if you are the person, if you are an adolescent or even if you are, remember, type type 1 diabetes mellitus doesn't occur only in children. It can happen to anyone. Okay. So whether you are a kid or not, when you are sick or in your times of illness, that is what we call sick day management. What should you do? Or how should you manage your condition? The first one, we are saying never skip insulin. Never skip your insulin. Otherwise, you will make your condition worse. Or whatever thing that is happening, you can even complicate it by adding up what DKA to it. All right. Of which you wouldn't want to push yourself into that situation. The next one, check blood glucose every 1 to 4 hours. Okay, so if let's say you are at home, you've been doing it, let's say once daily or as and when needed, when you are sick, especially in the hospital or wherever, you have to make sure that from anywhere between 1 to 4 hours. Some other times we do kill for, okay. Every 4 hours you have to know your level of what? Blood glucose. It's very important. Then monitor urinary ketones. Okay. It helps for you to know whether DKA is already setting in or something. Okay. When DKA settings, you have ketones um, being produced in your urine. Maintain hydration. Hydration is the key. Remember, even when it comes to DKA, between so no matter how they will frame the question, when you have an emergency like DKA, what is your priority management? You give so between blood, oxygen, and IV fluids, which one do you give?
IV fluid.
Besides the IV fluid.
You give IV fluids. Which type of IV fluid is preferred mostly?
Normal saline.
Yeah,
Normal
0.9.
That's
Good.
right.
0.9 sodium chloride. Okay, or normal saline. That is mostly preferred. Okay. I've seen it somewhere that Ringer's lactates can also be allowed. Who have seen it somewhere before? I once read it somewhere.
Yes, I've also seen it.
You've seen it somewhere, right?
Yes, they said in
Yeah,
case you
so
don't have the ringgit,
good.
it
Good.
wouldn't cost
So
any difference.
yeah. So I was reading at a point in time somewhere and I found that too. Okay, but I mean your first priority thing is just think about NS first. So in questions, when you don't see normal saline and you see Ringer's lactate, it's still isotonic fluid. I think you should still choose it. Okay. But where you see normal saline like 0.9 sodium chloride and other IV fluids, choose normal saline. Okay. So that is one thing about that. Okay. And you have to what? Adjust insulin as needed. Okay. Adjust insulin as needed. It's very, very important. So if you check your either if you are doing Q4 or you are doing Q2, depending on what's happening, is your blood glucose level will determine. Okay. We have proposed insulin skills around which your doctor can prescribe, okay, whether low dose, medium dose, or high dose. Okay, so adjustments can be made depending on your blood glucose level. All right, now this is what happens, okay, during your sick day if you have diabetes mellitus type 1. So we are trying to relate it to DKA. Remember, illness itself is a stress on the body. Okay, when you are sick, it's a stress on the body. And stress hormones go up. Okay, you have cortisol level. Your cortisol level will rise. Okay, normally, when cortisol level rise to, you have, cortisol influences blood glucose level to go up, right? Especially glucocorticoids. Normally, we mention the term cortisol, or or let me say that. Okay, cortisol. Your cortisol level will go up so that it covers everything. When cortisol levels rise up, your blood glucose are likely to also rise up. But let's leave that one. Let's see what's really happening. So, like I was saying, illness itself is a stress on the body. So, whenever you are sick, your stress hormones go up as your cortisol levels go up. Then you your insulin resistance also becomes very, 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 very high. Okay, because stress hormones affect the sensitivity to of your body cells, okay, or body tissues to be sensitive to insulin. Okay, stress hormones, it's like when we were trying to do the Alzheimer's disease, or let me say the myasthenia gravis, when you have receptor site being blocked, when you have cortisol levels, or let's say stress hormones being high, they increase insulin resistance. Okay, they increase insulin resistance, and because the body should still, or the cells should still get some glucose in them, they tend to break down. Okay, you have the cells breaking down to get glucose by themselves, and that is how come you get ketones being produced in urine. Okay, as they break down, within tissues you have fats and all of that, right? So if the body cells cannot get glucose directly, normally they should get glucose. If they are not getting glucose, then they're going to break down, their own self down. Okay, going to rely on fat. So the tissues contain a lot of fat, so they will break down themselves in order to release some energy that they can use them up. All right. And alongside, you have ketones being produced. And that is where your emergency starts. That is AKA. That is where it starts. I'm trying to use simple layman terms to explain what is happening so that you can understand. If you have any question, you can ask before we carry on. Okay. All right. So on the egg list, you'll be given when you're giving blood sugar levels, you'll be given both in milligram per deciliter and millimole per liter. The US and most parts of the world, they make more use of the milligrams per deciliter. Okay. And in Ghana and some part of other African countries too, we make use of the millimole per liter. But on the egg list, you'll be given both. So you see one written, then the other in a bracket. So hypoglycemia, like we said before, this is not our first time of hearing hypoglycemia. So that is where you have your blood glucose level below 70 milligram per deciliter or below 3.9 millimole per liter. Okay. And these are what you see, the signs: sweating, tremors, irritability, tachycardia, hunger. Okay. So you have, you see, your blood sugar will be very, very high, but you'll be very hungry. Okay. All right. So how do we manage hypoglycemia in this case? This is how we manage hypoglycemia in the conscious child. It's also similar to an adult. Okay. So just take note. When the child is conscious and the child can swallow, please, it is always advised. And on the necklace, okay, when they give you any scenario, sometimes they will not tell you straight away that the child is conscious. Okay, let me try and see if I can form an example for you. They will be like, you are caring for maybe a 13-year-old boy who happens to be irritable, okay, and complain of hunger with uh, severe maybe perspiration or sweat. Like, they can give you any term that could mean the patient is sweating heavily, okay, and the patient complains of hunger. All right, something like that. Okay, so those signs that I'm mentioning, it's a clue to tell you that the patient is conscious. All right. So they'll just make sure that you get the idea of what hypoglycemia happening. Okay. Then they will tell you maybe your options. Or maybe the main question will be like, how are you going to manage this patient? Or what will be your priority intervention for this, 13-year-old boy or girl? Then you will see if 50%, like 50 mils dextrose, okay, IV. Then you see, you see all the treatment modalities over there. Please don't rush. Even for an adult, for pediatrics, we even have a different way of even treating their hypoglycemia, even if they are unconscious. For adults, the standard one is what, 50 mils, 50% dextrose, right? Yes. For depending on the age, I can't actually tell the age, the cutoff age, but in pediatrics, mostly they use the 10%, depending on the age, okay? 10% dextrose. Start with that one rather. So if it's an adult, so, or maybe whoever, they will give you all the clues, all the treatment modalities. So you see IV there and everything. Please, the clue is, if they give you an idea of how conscious, or let's say the level of consciousness of the patient, and you are able to tell that the patient is conscious, let the patient take in something oral. Okay, don't give anything IV or IM. Let the person drink something sugary. Okay, so here is it. Normally, we have 15-gram fast acting caps. Okay, so in options, they can give you maybe a juice or sugary candy or honey, anything that is sweet. Okay, so that will be your answer in such cases. And I've seen questions on that before. That's why I'm just trying to draw your attention. And I believe some of you too have seen some before. All right. They will not just tell you patient is conscious. They can just describe what is happening. So you should know that the patient is conscious or not. Should you get the other hours, okay, the other side of it, you will know that the patient is not conscious. If they tell you patient is somnolent, the patient is somnolent and easily falls asleep. This patient like this, you can't trust the airway, okay? So you will have to keep the patient NPO. Then you will rely on your other ways of resolving hypoglycemia. I hope you are all getting it. So after giving it orally, you check you recheck your blood glucose after 15 minutes. Okay. All right. And over here, we are saying if the patient is unconscious, okay, if the patient is unconscious, you can give IM glucagon. Okay, you can give IM glucagon. You know what glucagon does, right? What does glucagon does? So this
I
is the first time
remember
I'm
you
hearing
said when there
it.
is when patient is unconscious and then that could done IM. I remember that one. It's another form of insulin.
Is glucagon another form of insulin?
I remember you said that when there is no IV, access to IV, we can give it IM.
Good, 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 good. It is very, very, very nice. You remember. I'm glad you remember. Okay, so let me repeat this one here too again. Okay. Let's take it as an adult. Okay. I want to generalize something. I want to take it as an adult because for every adult, we have a standard way of treating, especially if you are doing IV. And that is 50 mils, 50% dextrose, right? Okay. So let's say you have an adult and there is no IV. Patient is hypoglycemic. I mean, patient is hypoglycemic and patient is unconscious. Please don't think of what IV 50% dextrose. I mean, those things. Don't think about that. Give IM glucagon straight away. Okay. But if you see options, okay, if if let's say you get hypoglycemia question, um they don't specify, okay. If you get if you get hypoglycemia question and they've not specified whether the patient has IV or not, okay. Yes, let us leave that one there. I just want to um I mean give you a point here. Let's say patient patient is unconscious. That one is established. Okay. Patient is unconscious. And patient is hypoglycemic. The first thing to do, you know that you can't do anything orally. So that one is ruled out. The first thing to do is your IV 50 percent dextrose. If you have that option available, that would be your first thing to do. Okay. And in questions like that, hypoglycemia questions like that, you will see give 50% dextrose, and you will see give IM glucagon too. Okay, you see all those things there. Okay. When you see IM glucagon with IV dextrose, please choose IV dextrose, the 50%, um, 50 mils. Okay. When you see I'm repeating myself again. When you see IM glucagon and you see IV 50% dextrose, like 50 mils, your IV becomes your priority compared to your IM. Because even looking at the route of administration, oh sorry, route yes, looking at the route of administration, which one is being absorbed first? IVs are being absorbed first. Okay, you just go into the blood and you see the effects right away. All right. So you give IM glucagon when you don't have IV access. So this is just to stress on that. Okay. All right.
Excuse
Any
me, boss.
question?
There, are you saying 15% or 50%?
50. So it's like we call it 50
Okay,
rule,
five
like something
zero.
like that.
Okay.
50, yeah. So 50%, 50 mils of dextrose. Okay. And it is very, very thick. The concentration is very, very thick. So if you have a bigger vein, like a central line, you prefer that one the peripheral. Otherwise, you can even blow the peripheral line. Yeah, you can damage it. It's very, very quick. Any question over here? I hope everything is well understood. Can we continue?
Yeah, boss, yeah, please, I
Yes.
want to have a question.
Okay.
Please, I didn't capture the right time to give the IM glucagon.
When there is hypoglycemia and the patient is unconscious and there is no IV line, do IM glucagon. Do you get that part?
Yes, please.
Okay, but when there's IV access, or even when the question does not tell you whether there's IV access or not, you have to know everything is there. Okay. And among the options, if you are given IM glucagon and IV dextrose, the IV dextrose will be your priority than IM glucagon. Do you understand that statement?
Okay, so what you are saying is you choose the IM glucagon if there is no IV
Yes.
dextrose.
Hmm.
Okay, okay, thank you. Please,
Yes.
also when you were talking about the DKA, I want to know, is it always that the the fluid comes first, irrespective of the respiration? Like when they mention oxygen, and then hey, so should you always choose fluid first?
Okay. So the simple answer to your question is yes. Okay. And if I should explain small, okay, I'll not go into details that much, but if I should explain small, remember you're going to get cosmal respirations. You know what cosmal respiration is? A very, very bad pattern form of hyper respiration. Like your respiratory rate will
Yes.
go higher. You can even get around late 30s or 40s breath per minute. Okay, you can reach that far. You'll be panting, you'll be open. So all of these things will be happening. But trust me, if your fluids are not well managed, and I mean the time is also part. Okay, the time management or the time that we should give the fluid is also part. Even if it delays, multiple organ damage will happen. Okay, so what is happening is because you need fluid. In BK, okay, all the like increased respiratory rate, tachycardia, everything happening is because you are dehydrated. I mean, severely dehydrated. So we tackle the root cause of the issue than just the symptoms. Okay. So it's like right now, if you have, let's say if you have malaria, okay, I hope everybody here knows malaria. If you have malaria and you are you are you are vomiting, okay, you are having headache, and you choose to rely on only painkillers to treat your headache, do you mean to treat something or do you mean to tackle something better with your condition? No. So you tackle the root cause. And for this one, it's emergency. Dehydration, if you don't take care, it's like bleeding. That's why um I don't even know how to even make this serious for you to even understand or appreciate it. When you are losing fluid, the time for replacement is very, very important. Other than that, we will lose you or we are going to get irreversible organ damage. And it cannot be, or it might not be only one organ. You can have lots of organs shutting down. The kidneys are very, 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 I mean, they are one of those fast organs to shut down. And when they shut down, that is all. Can't get it again. Okay. Then you can have other organs following. So in everything, like when you're getting, let's say when you are losing fluid, dehydration, like severe vomiting and diarrhea, even if your respiratory rate is 60 beats, no, 60 cycles per minute, please, the priority is fluid. Just give him fluid and you see symptoms being resolved gradually. So in this case, back to DK, no matter how the scenario looks like, okay, if it's DKA and you have fluid, I mean, except maybe if the person has told you that fluid have started and maybe you need a second thing to do. But if fluid has not started, your first thing or your priority will be your fluid replacement. Okay.
Okay, please, thank you.
You're welcome. Any other question? All right. I think we are all
Rosdia,
good here. We've said a lot of
Rosdia,
things. Yes, sister.
if you give the IM glucagon, you will still need in real life. You will still need an IV access, isn't it, to prevent the rebound effect, right?
Yeah. So for the IV, you need it when you're treating any emergencies. Okay. So most of the times hypoglycemia, it's like an emergency. You can't wait. You need something just to raise the sugar up quickly. Okay. So um, and when you are in situations like this, sometimes your IVs even collapse, your intravascular spaces collapse. No. So it's even difficult getting IVs and it delays. The more you delay, hypoglycemia will not wait for you. And you can arrest, like it will you will see cardiac arrest happening and it will complicate everything. So IM, then later, I mean, if you're hospitalized, definitely you will need an IV. So IM first, then whichever thing that has to be done will be done later. Okay, like the IV setup and all. So the glucagon, good. If I should understand, maybe yeah, I get a part of why you are asking the question. So the IM glucagon is just to save you from your hypoglycemia episode. It doesn't mean that it's an absolute treatment, like one-time treatment, and that is all. If that is what you are trying to ask, okay. Even for normal hypoglycemia, even for an adult, when we give the um 50%, 50 mils dextrose. After we do set up some kind of dextrose, sometimes physicians will want to do maybe 10% dextrose running for some time before later they DC it or they discontinue it. So that is like a part of continue. You don't just correct it and you leave it for it to continue doing magic. Okay.
Because it will rebound. It will go. It
Yeah,
will go back down after some
yeah,
time. It will go back down.
yeah. Any other question? All right. If not, then we can continue. So after hypoglycemia treatment, what do? We recheck blood glucose. If the patient is conscious enough and can eat, you give meal or snack. And if meal is delayed, okay, if let's say they're in hospital setting, if meal is delayed, you can give them something handy, okay. Um, Anything carbohydrate and protein like peanut butter, you can give it to them, okay. And please, when you are treating this, it doesn't even make sense. I don't think anyone will do that. Someone who just received an insulin correction, sorry, hypoglycemia correction, why would you even want to give insulin again, even if the person is scheduled and it's time for the person to take it? Why will you even give it? Okay, so um, common sense in the knowledge of hypoglycemia treatment will tell you that don't give it. And when you correct it, most of the times when you correct the hypoglycemia, you're likely to get, not always, but sometimes you're likely to get the sugars shooting up. Please don't think the sugar is high as at that time, so you're going to give insulin to correct it. Please, no. Okay. the sugars will definitely come down again. Okay, so that is what it means. All right. Then there is something that normally they ask questions on very well. Look at this part. Who have seen questions on this before? Sometimes it will be like a 6-year-old boy with diabetes mellitus. Okay, is being taken care of something. What are some of the tasks you can delegate to the the, the child? Okay, with the diabetes type 1 to help in self-care, something like that, questions like that. I believe most of you have seen some before, right? So that is why this thing is here. Please, glucose,
Yes. Sorry, with the hypoglycemia and then the insulin, after you've given the glucagon or the dextrose saline, the dextrose,
not
sorry,
like dextrose, yeah.
dextrose. Yeah, we all know we should hold on the insulin, but in this condition, we know that the pancreas is no more producing insulin. So after you've given the dextrose, definitely the glucose the glucose level is going to be high in the blood. So
Yes.
which insulin will take it to the cells? That's my confusion here. Like, I want to understand
Okay.
that.
Okay.
Yeah.
Do you understand? Do you understand his question?
Yes, sir.
So who can try? Who can help? Who can help answer him? Who has an idea?
But yeah,
Yes.
I wasn't here when you started. I came late. But when you give the iron glucagon and all those things, you get a false negative high blood.
Can you please speak up a bit? I can hardly hear you. Your volume is down.
I'm saying that I wasn't here
Mm-hmm.
when you started the class. But what I know is that when you give the iron glucagon and then the PCPT, usually when you check within like 15 minutes, you usually get a high glucose level. Usually we call it negative. How do I even say it? It's not the real, if anything, it's not the real glucose the person is supposed to get. False positive. So if you are going to give insulin, you're going to worsen the whole thing. That's what I think.
If you're going to give what? I hardly heard you.
If you are going to give insulin,
If you're going to give insulin,
yes, you worsen it. You end up getting another low glucose and you end up bringing it up again. That's what you keep doing. So you need to stabilize the patient first. And then you know that, oh, this glucose I'm getting or this RBS I'm getting is the right RBS before you go on to manage your RBS.
well, I heard parts of what you said, but I didn't hear some parts. Um, your voice is very down, but anyway. Um, anyone, thank you for your submission. Okay. Anyone who wants to add up, I hope we all get his question. Okay. In I don't know whether there is another explanation, but remember in diabetes type 1, there is little to no. So there could be some form of insulin. Okay. That is one. But I don't know if there is some other reason. I'll touch on what I just said to details very soon. I just want to know if someone can say something else.
Hello, please, can you repeat the question again, please?
Brother, can you repeat the question?
Yes. Okay, so my question is, we all know that when you give, like our sister just said, when you give with the hypoglycemia, when it happens and you give the dextrose, the dextrose 50%, after some time, you check, and then normally you see a very high glucose level. You understand? Okay, but in this instance, we've been told that we shouldn't give insulin. We should wait by it to stabilize. And I'm asking that we also know that with type 1 diabetes, the pancreas is no more producing insulin. So if we leave, because when the glucose is the glucose is high initially, it means that the glucose is just in the blood. It hasn't got into the cell. That is why it is there. What you have given it is in the blood, high in the blood, but it hasn't really got into the cell. That's why it's high. So it needs something to push it there, insulin. But in this case too, the pancreas is not producing insulin. So how? I mean, as we shouldn't give, how will it get there? I mean,
you see, the answer is very simple. The answer is very simple, but I want to know how. Maybe
I don't know if you got my question right. My brother who just asked.
Do you understand this question?
Yeah, I do.
Yeah. So for those of us who are still thinking, okay, so yeah.
Sir, let me try. I was thinking, since it is a false negative, if we give the insulin, it will cause the rebound hypoglycemia. It may cause the hypoglycemia to come again.
Yes, that is true.
Because in the body.
That is true. But what he's asking is that in type 1 diabetes, there is little to no insulin. Okay. So why should we still treat with IV dextrose? Because there is no insulin. Let's say in the case where there is no insulin, okay, to send the glucose into the body tissues. So why do we still give the dextrose to correct while there is no insulin? The answer is very simple and tricky. Do you understand his question now? Because even if we give the dextrose, the insulin is not there to carry it to the body cells. Do you understand? Do you understand the concept where he's coming from?
Yes, we do.
Okay. All right. In order to speed up things, right, let me tell you something. Maybe there's something that our mind. You see, we are thinking plenty. I think initially I was also thinking plenty, but the answer is very simple. I get it here now. Let me ask you a question. What is hypoglycemia in the first place?
Low sugar in the blood.
So that alone will answer the question. I don't know if someone is thinking what I'm thinking. Okay. So hypoglycemia is when you have low blood sugar. Okay, the sugar content in your blood is low, not the sugar content in your body cells. The brother who asked the question, are you here? That is why when we want to test for blood sugar, we pick it right from the blood. So hypoglycemia is a situation where the sugar content in your blood is small. So you want to replace that sugar. So hypoglycemia is not about taking sugar into cells. It's about the sugar itself in the blood. Have you been answered? Is someone here?
I think what he wants to say is, how do we do away with the high sugars after we give the 50% since it's still in the blood and it's recording high sugar? So he wants to know how we get.
Yeah. Wait. Let's let's take it. Let me repeat myself, okay, and link it to something. I'm trying to draw your attention to this again. What is the meaning of hypoglycemia? Remember, his question is, why do we treat people with type 1 diabetes, right? Why do we treat them with dextrose if they have hypoglycemia? That was his question. Because, and he added that because there is no insulin to carry the glucose into the cells.
Boss.
But correcting, was that your question?
No, it's not about why do we treat it with dextrose.
Okay,
it is about it is about why is it that you don't give the insulin? Because the insulin will have to, it is the insulin when you give the dextrose, it is the insulin which will have to, push it into the cells. So if you don't give it in this instance, how is the insulin going to get to the cells?
Okay, so wait.
All right, it's not about the dextrose.
Okay, fine. So when you have hypoglycemia itself means that the sugar in your blood is low, not the sugar in your cells. Are you getting it? Hypoglycemia means the sugar in your blood itself is low. So why even think of insulin in the first place?
Well, insulin is for hyper. So why are we using insulin here?
Yeah, so why should you even mention insulin? Yes, when so in this case you don't have sugar. Hypoglycemia means
maybe you don't understand what he's trying to say. What he wants to know is the sugar goes high after the 50% dextrose administered.
Exactly.
Okay.
Yes.
Now you still do another procedure by you don't want the person to rebound. Okay, you give IV maybe 10% to stabilize the sugar. Now maybe the person is recording high sugar of maybe 30. Okay, 30, and then you know the sugar is still high. How do you bring the sugar down? Or what does the body do in order to stabilize this sugar? Since you are not giving insulin.
Okay, so then that's your question.
Yes, exactly. And the pancreas is not producing insulin. So how do you get it down?
That's quite an easy question. For this one, it's very easy. Okay, so you see, we were talking about hypoglycemia initially. Remember, it is hypoglycemia that will kill you. Okay, that is why when someone is going into hypoglycemia, we don't care, when we are correct, we don't care about how much the sugar will go initially. Like, how high. Because definitely after some time it comes down again. Then we have protocols to stabilize the sugar. Okay. So when it comes to hypoglycemia treatment in diabetes mellitus, the first thing to do is just push sugar in. When sugar is in, even without even the correction, people with diabetes type 1, they are already on scheduled insulin. Okay, they give themselves shots. All right, that is if they are walking, if they're not hospitalized, they are just giving themselves shots like as scheduled, right? If it's an emergency and we want to slow or we want to control things, maybe doctors would want to prescribe what we have insulin infusions that you will be, and all of these things are ICU management. You have to be on a continuous cardiac monitoring. Like lot of other things will have to be in place. You can't be managed for this condition just on the general ward. Okay, so if your sugars are high, it is very easy. It's always insulin that we use to correct. So that's a very easy question. Okay.
So, boss, I think.
Oh, I'm not still getting it.
I think his problem is that he hasn't differentiated between hypoglycemia and type 1 diabetes. Maybe he's
no.
That one has established. I understand those.
You see, he's trying to say that once we stabilize the person and now the person is recording high sugar, maybe 30. Okay. Now we've withheld the insulin. How will the sugar drop? Since since we are not giving the insulin for the glucose or weight to get into the cells, how will the sugar drop? How will we manage the person? You get it?
Okay,
Since the
let me.
insulin has been withheld.
Hello, let me come in small. I think we are still talking about the same issue. Initial, the guy question was when we give the sugar to manage hyperglycemia and we are not giving insulin, how will the insulin be taken into the cells? That's why Bosgia said we are dealing with hypoglycemia. Hypoglycemia means low sugar in the blood. So if you are managing hypoglycemia, your concern is to raise the sugar level to a desirable level so that the patient do not get organ damage. After the hypoglycemia has been resolved, if the person still having a high levels of sugar, we have protocols in managing the high levels of sugar. We held the insulin initially because we know the person is having hypoglycemia. And so once it's hypoglycemia, like boss was saying, it will not make sense to give insulin, what do you call it, sugar, and then be giving insulin again. At the instant we are giving the sugar, we hold the insulin so that the sugar level in the blood, not the sugar level in the cell, the sugar levels in the blood will rise to the level that we want. That is sustainable to prevent organ damage. After we sustain that one and establish that one, if the sugar is still high, it means the hypoglycemia has not turned to hyperglycemia, then we go to hyperglycemia management. Thank you.
Exactly.
Yes.
He has explained it all. He has explained it all. Exactly.
Yeah. Yeah. So that's the same thing we're talking about. Thank you for wait before we come in. Is this Frank? Frank?
Yeah.
Is this Frank?
Yes.
Okay, you can come in.
Yes, the thing is that you should know that not all cells will need insulin in order to for sugar to go into the cells. All right, there are cells which can take up sugar without the help of insulin. So whether the hypoglycemia in the blood or cell, because once we have hypoglycemia, it means that sometimes it's a reflection of what is in the cells. Okay, so it might be that there can be hypoglycemia, low sugar level in the cells as well. Okay, but mind you, not all cells will need insulin to take up sugar. Like for example, when you take the brain, it doesn't need insulin. All right, insulin can just glucose can just cross the blood-brain barrier right into the brain. Okay, so once you give the glucose in the blood, some of the cells, sometimes the liver, doesn't need insulin. So all these cells will take up on the glucose in the blood. And if you don't, but what about the cells which need insulin? That's why when the patient recovers, because those which don't need insulin to take up sugar, they will rather be, the effect will be on the brain. You see, when someone is getting hypoglycemia, the brain is going to suffer most. Okay, so once you give insulin, the brain is going to take up the glucose, and then leaving the one that can not transport glucose without insulin. So when patient becomes stable because there's sugar in the brain, later we need what? Insulin to transport glucose into those which will need insulin as their transporter. You get it? Yeah. So that I think that is
answers my question perfectly. Thank you.
Yes.
This answers my question. Yeah, this makes a lot of sense.
Good.
Thank you.
Good. Then I will not say anything again. Thank you, Bro Frank. Yeah. Any other follow-up questions?
So boss, please, I think when we were talking about the hypoglycemia to about the adults, you made mention of 50-50 dextrose for the adults. Unfortunately, I didn't hear about the kids or the young, maybe kids.
Oh, I said that pediatric management is different, and don't even use the 50 percent. They normally use the 10% dextrose.
Okay.
I said yeah, and I think it's weight based. Okay, it's weight based. Yeah, pediatric management of hypoglycemia is different from an adult.
Okay.
Any other question? All right. Thank you for bringing all of those things up. So they are all eye openers, right? Okay. So now back to what we were trying to discuss here. When I give an example like a 6-year-old child, okay? When a 6-year-old child wants to, or something that you can do to encourage them to be part of the care of their own condition, they can assist with what? Glucose checks. Okay, so when questions are like I can you can give maybe the how do we call that device with that needle that you use to prick yourself? Yeah,
Is
we
it
have a nice name.
glucometer? Glucometer.
No, like
Lancet
Lancet.
device. Glucometer.
Yeah, Lancet device, but there's another name for it. But fine, if we can understand Lancet device, the one that it has that small needle with I mean a button that you press, then you know it's yes, so that's the device I'm trying to talk about. So you can give it to them to stick themselves, okay, during blood glucose check. It's okay, you direct them. So when you get questions and it's asking you what are some of the things they normally give questions I've seen around these areas, they normally give age specific questions like that. So if the child is 5 years, 6 years, school going age, you can guide them.
Is it my network or is Gia your network? Because it's kind of breaking.
Am I breaking?
No, maybe
No.
it's not.
Oh, okay. All right. All right. So they can stick themselves. Okay. So just take note of that part. Then they can also select injection sites. Okay. They can select injection sites. So already they've had an indication that they can take it on their thigh, on their abdomen, upper forearm. Okay. Just upper forearm, like upper arm. Okay. On the upper arm, you've chosen sites for them. They can, as part of, the management, they can choose that maybe today I want to be giving the insulin maybe at my left thigh, or I would want to take it on my tummy. Okay, maybe I would want to take it on my right thigh, or maybe upper right arm or something. So you can encourage them. They are capable of choosing sites. They don't say that, or don't think. First time I saw questions on this one, I was biased. I was like, this case, what did they do? So you have to do. They can't do all of these things, but it's as part of management. It helps to even motivate them to be. I mean, it helps them to feel part of the care. Okay, so with your guidance, they can select injection sites, they can assess the glucose check and even choose sites, okay, stick themselves with guidance, okay. Then you have to teach them to recognize what signs of hypoglycemia or hyperglycemia, okay, the symptoms. And like I said, they can participate in insulin administration. So when they are like, I'd want to give it today with your inspection, you guide them, then they can give the shot to themselves. Most of the times, wrong questions will when the wrong questions come, you see. Just I can't brainstorm any of them right now, but the wrong questions or wrong options, when they mix up with all these things, you will see that you'll be able to figure it out that that is something above a school going age child to be able to do. Okay. So as soon as you see that, then you rule that one out. But this one is just to let you know they can do this to help with their self-care management of type 1. All right. If you have any question here, you can ask. So remember we were doing some pediatric disorders, right? So we've talked about diabetes mellitus type 1. So normally tricky areas are the management. Yes.
So please, I said, is it safe, if the child decided to inject at the bottom, is it advisable?
If the child chooses the Botox?
Yes, is it advisable to inject at the bottom?
Why should the child choose the Botox in the first place? For
But
subcut.
you know some children, yes, they can tell that I want, as you discussed earlier, you said the children, they can choose their type of injection. And I'm asking,
yes,
what about if the child chooses the Botox? Is it
so generally,
advisable?
okay, so generally when questions come like that, remember, yes, they can choose the very site, but if certain sites are unfavorable, you can correct them. They can't choose just anywhere. How can a 5-year-old or 6-year-old child inject like subcutaneously at the buttocks by him or herself? Is that feasible? I don't think that is feasible.
What I'm trying to say is that, like the 5 years old child, I know the child cannot inject him or herself. So maybe they will direct it to the mother or the guardian.
Okay, just choosing the site. No, you have to correct them. No. I mean, why will you even do self-cuts at a buttocks? No. That is not favorable. Yeah.
Okay.
So when they choose wrong sites, you can guide them. It doesn't mean you don't have subcutaneous tissues in your bottles. We have, but that is not a desirable place for subcuts. Yeah, so you have to correct them.
Yeah. Okay, thank you very much.
You are welcome.
Hello.
Yes.
Hello, sir.
We have many people talking. If you want to talk, raise up your hand. Let me call you. Who wants to talk first? Abigail, let's go.
Yeah. In terms of their the size, allocation of the size, it is you the nurse. You educate them on some of the favorable sites, and then they will, based on the information you have given them, they will choose their side. So it's not like it has been given to them blurred that they should choose anywhere they want.
Yeah. So that is it. Okay. So per your supervision, okay, then you guide them to choose sites, not just anywhere. Okay. Thank you for that submission. Esther Ama.
Yes, sir. So at what age can they be involved in the care, as in the management of their care, like they're choosing the site? Because all the questions I have seen, I think that it is
You've seen
mostly
questions on that before, right?
school age. Yes, so school age. I think I've seen it twice. Even yesterday, I think I saw one. So I think it's usually, most of them, it is school age that I've seen.
So I think school age will fall between, some will give 5 to 12. Some also give 6 to
so that yes,
6
so
to
it's
12.
between 5 to 12 years.
Or 6 to 12, something like that. Yeah. So sometimes they will say 5 years. 5 years can do that. 6 years can do that. up to about 12 years. When you get to 13, 13 is like teenage, right? So from anywhere 5, 6 up to 12, yeah, that is where they normally ask the questions for.
All right, sir.
Okay.
Thank you.
All right. Is that Precious?
Yes, boss dear. Please, concerning the administration for the children, what I read is that the adults, who is the caregiver, will inject, and the child will then push.
Will
Is
push,
that
okay.
yeah? Is that only the right way, or the child is also allowed to inject and then push?
Okay. So that is a nice way. You see, questions yeah, I like how sometimes Marquis will even say it depends. Okay. So look at the example you gave. The child chose and the caregiver injected but didn't push the drug in and the child pushed. Okay. So it depends. But always look out for how the sentence has been written. Okay. They can choose site with guidance. That is correct. If they can give, they can give. Okay, let's say if you have a 10-year-old baby, or should I say baby? Maybe so a 10-year-old boy or 10-year-old girl, with guidance, they can give themselves subcut shots. They can, with the guidance. Okay, so choosing the site and for them to push the medication after you've inserted, that is also correct. Okay, but when they tell you, please be careful, sometimes the wording can be very tricky. If you suspect any sentence that doesn't come with supervision, like child, maybe the child injects him or herself, like I don't know how, I can brainstorm and give a tricky question, like a tricky sentence like that. But if you suspect anything that there is no supervision and harm could result, please don't choose that option. Okay, so it all depends on the wording, but they can choose if they are school age children with supervision, they can inject. Subcut, they can inject. Okay,
Okay, thank you.
yeah. Any other question? Okay, so as part of the disorders, the next thing to talk about is tetralogy of, how do you pronounce this? Is it fallot or fallow? Tetralogy of fallow, right?
Follow.
Hello.
Okay.
Yeah. Hello.
So when we say tetra, tetra means 4, right?
So,
Tetra means 4. So tetralogy of fallow talks about 4 main defects. It's all around the heart. Okay. Let's look at this one. On our left hand side, the first one being pulmonary stenosis. There is a nice way to remember this, a nice trick. Okay. Let me see if I remember. It's like prove, right? Yes. Let me pick up my pen here. So it's like prove. P-R-O, then the V, you add this small E. Okay. Some will even say that prove that you have TOF. So like as a sentence. So prove that you have TOF. Okay, prove that you have the trilogy of follow. Some just use the word, prove, just to remember the 4 things, right? That is happening. So the first one being pulmonary stenosis. When you say pulmonary stenosis, I hope you know what it means, right? Pulmonary stenosis. When you hear the
Yes,
word
please.
pulmonary, what does it mean? pulmonary stenosis
Pulmonary
can contain your
Islam.
lungs. Okay. So in pulmonary stenosis, what happens is that you have please, stenosis is the same as narrowing. So just in case you are wondering. Okay, so pulmonary stenosis is where you have your pulmonary artery, especially. Okay, your pulmonary artery becoming narrowed. Let me see if I can show you a picture here. Let me go. I don't know if I can get a nice heart diagram to demonstrate something to you. So let's see pulmonary artery. Let's use this one. Why is it not opening? Okay, so let's just use maybe this one, right? So that's here on our right hand. Oh. So that's it on our right hand side here. Okay. I think the picture is clear now. Can you see it well now? Oh, the more I try to make it bigger, the smaller it gets. All right. So let me see. Yeah, I think it's fine this way. It's bigger now. Yeah, so look at this well. You see this one? This is your pulmonary artery, right? So the pulmonary artery is the only vessel within you that carries deoxygenated blood. Generally, you know that arteries carries what? Oxygenated blood, right? And veins carries deoxygenated blood. So this is the only difference. Okay, artery, it is called artery because it's carrying blood away from the heart. So any vessel that is carrying blood away from the heart is called artery. Okay, and any vessel that is carrying blood towards the heart is called a vein. So this is carrying blood from away from the heart. That is why it's called an artery. Okay, but look at where it's connected. It's connected to the right side of the heart. So look at the inferior vena cava and superior vena cava. Blood from upper part and lower part of the body enters the right side of the heart. Then they pass through the pulmonary artery. Okay, these pulmonary arteries, they are called pulmonary because they are connected to the lungs. So they pass through when the blood gets to the right ventricles, right? They are carried through the pulmonary arteries into the lungs for oxygenation. So all the blood that is passing through here, the pulmonary artery, they are deoxygenated because they're coming from various parts of the body. Okay, and they are now going for oxygen. And after that, they will pass through pulmonary veins. So you see, these are the pulmonary veins too. So these are veins which carries blood towards the heart. But in this case, what is the nature of the blood they are carrying towards the heart? It's oxygenated blood. That is why this also is very different. Okay, the pulmonary vein too is the only vein in the body that carries oxygenated blood. So it carries blood to the left side of the heart. Then after here, it will pass through the aorta. Then the blood will be distributed to all parts of the body. So this is just a simple way of how circulation happens in your body. Now, by understanding this, remember we are saying pulmonary stenosis, right? Remember the proof we talked about. P for pulmonary stenosis, R for what? Right ventricular defect. Right ventricular septal right ventricular hypertrophy rather. Okay. O for what? Overriding aorta. We will talk about that too. So we will use this diagram. Okay. Then V for what?
Ventricular septal defect.
Septal defect. So this diagram can help us explain everything perfectly. Okay. Yes, it can help us explain everything perfectly. All right. So we are looking at pulmonary stenosis first. So this is where you have the pulmonary artery becoming narrowing. So you see, let me pick up my pen here. So you will see this vessel, instead of opening up, you see it's narrowing. Okay. So instead of that big space, it will narrow. Okay, even though there will be space, there will be some space through, but it will narrow, which means that blood from the right side of the heart cannot easily pass through this vessel. Okay, to send blood to the lungs for oxygenation. And when that happens, what do you think will happen? When the blood cannot easily flow from the right ventricles to the lungs, what do you think will happen?
Goes back into the body.
Yes, it will push back, okay? And when that happens, so it means the blood that will come at the end of the cycle, like the blood that will come to the left side of the heart, will be very small and they will not carry enough oxygen to supply the entire body. Okay, because remember, you need more of blood. Okay, you need more of hemoglobin to bind to lots of oxygen, right? Before you can equally. So oxygenation itself has or let me explain this for you to know. Do you know why? Okay, let me draw your attention to something. You see, when someone has hemoglobin of 4, okay, even though you can give the person high flow 100% of like any better or any best oxygen you have, but the person will still be this. The person will still be having respiratory issues or like will still be panting. Do you know why? Because it is not only about the oxygen, it is about the number of hemoglobins to bind to the oxygen. So link it to what is happening here. You have less blood because of the stenosis here. You have less blood going to the lungs for oxygen. So it means you have less hemoglobin to being exposed to oxygen. And these few hemoglobins, or let me say whether hemoglobin, these few hemoglobin being exposed or being exposed to oxygen, they are responsible to supply the oxygen to all parts of the body, of which it will definitely be insufficient. Okay, so that is why at the end of the day, you see them becoming cyanotic. Okay, please remember with all these 4 things happening here in tetralogy of fallot, I want us to strike some difference. I know this is not anything new for us. They all cause cyanosis. Okay, and we shall look at some differences. They all cause cyanosis. All right, and we have some other heart conditions which do not cause cyanosis, and we will explain why those conditions do not cause cyanosis. All right. I just looked at the time, and the time is past. If you have any questions, you can ask me. Tomorrow, if God permits, we'll continue right from here. We can go and read more about the rest of them, okay? Why they can cause cyanosis and why others cannot cause cyanosis. And if you have any other interesting things you'd want to bring to life class, you can bring them up, okay? Any question right now? Or we should carry on for some time. Should we carry on? Okay.
Yes.
Let me stop. Oh.
Yes,
Silence
carry
means
on.
consent. Are you sure?
Yes, carry on. Yes.
Yes, we
Yes,
are
carry
sure.
on.
30 minutes more.
Yes. Carry on.
Okay. Let me try and see if I can finish with this and maybe one other. All right. Thanks for your permission. Sometimes I want to try and obey the time. But some people will be insulting me back though. All right. So um back to pulmonary stenosis. Okay. So there is sorry. So back to pulmonary stenosis, there is the narrowing of this vessel that you see. So I just explained how the cyanosis occur. Okay, because you have less blood going to the left side of the heart. Okay, I mean, you have less blood going to the
The
lungs
right
for
side.
oxygen to the left side. This side is the left side. Okay, you have less blood going to the left side. You know, you have less blood going to the lungs for oxygen.
And so less.
Then from the lungs, it comes to the left side. Yes, is someone talking? Okay, you have less blood going to the lungs, and that same less blood coming to the left side of the heart to be pumped into the body to supply every vital organ. So you're going to have less amount of like oxyhemoglobin. Okay, yes, in this case, like hemoglobin bound to oxygen. You need to have less number compared to the total number of tissues it should supply. So at the end of the day, you have issues with oxygenation and there'll be cyanosis. Okay. Now let's look at the next one. The next one here is where is my- so the next one here I think is overriding okay, let me see. Okay, so the next one here is right ventricular hypertrophy. So let's go to that one. Right ventricular hypertrophy. Okay, so let's see what's happening over here too with right ventricular hypertrophy. When we say hypertrophy means increasing the increase of number of words. Is it size or number? Hypertrophy is increasing the size, right? And
Yes.
hyperplasia
Yes,
is
increase in
increasing
size.
the number of cells. So hypertrophy here, right ventricular hypertrophy means that you have right side of the ventricles becoming what? Becoming thick than it should be. Generally and normally, God created the left side of the heart to be more thicker than the right side. Okay. And what's the reason? The reason is that it's the left side which is
Pumps
or which
blood
takes the
to the whole
burden of
body.
pumping blood to the whole body. So I always appreciate it this way. Whenever you feel your pedal pulse, your popliteal pulse, or your radial pulse, just imagine the work of the left ventricle. That small but mighty part of the heart here. Okay, pushing blood up here through the aorta to all parts of the body. So you can just imagine the kind of work it does. So that's why you should get that kind of muscle to be able to withstand that work, right? But the right side just pump blood through the pulmonary artery to the lungs, so it doesn't do much work like the left ventricle. So we have a condition, that's what we're talking about, right ventricular hypertrophy. So it's where you have the walls of the right ventricle with the muscles becoming thickening more than what it should be. Okay. And when that happens, what do you think will happen? Remember, we have pulmonary valves, right? we have this is the pulmonary artery though, but we have valves within the pulmonary artery. The valves prevent, in fact, all valves within the arteries, they have one common function. They prevent the backflow of blood. Okay, so all the valves prevent backflow of blood. Okay, look at the mitral valve. It prevents backflow of blood from the left ventricle to the to the left atrium. We have tricuspid valve too. Okay, over here. Another name for the mitral valve is bicuspid. So just in case you see some, because it's made up of two flaps, right? The tricuspid valve is made up of three flaps. That's why it's called tricuspid. And that one to prevent backflow of blood from the right ventricle back to the right atrium. So it prevents it. So we have pulmonary valves too, like inside here, okay? So that when blood moves up the pulmonary artery, there wouldn't be an easy backflow back into the right ventricle. Okay. So what happens over here in the right, like in right ventricular hypertrophy, is that the right ventricle works harder to push blood through the narrowed pulmonary valve. Okay. Okay. So when that happens, it's like when you gym, all right? It's like when you gym for very long, you build muscles, right? So that is what normally happens to the right ventricles. Okay, right ventricle, it's only one. So the continuous force that the right ventricle used to push blood, okay, through the narrow, like most of the times through already narrowed pulmonary artery or pulmonary valves, okay, the ventricles will have to push blood through. So if there are issues with the valves, being stenosed, or there are issues with the pulmonary artery itself, it's going to force a lot of work to be done by the right ventricle. And it's like gymming for a very long time, you build muscles. So that is how come the right ventricle become very thick. Okay, and in other words, we say to become hypertrophic or hypertrophic. And when that happens, what do you think will happen? It will get to a time the right ventricle cannot pump blood
Becomes slow.
through, yes, okay, through it again, and you have similar thing happening as in the pulmonary stenosis, right? You have less blood getting to the other parts of the body, and you can even have backflow, okay? The tricuspid valves too, at a point in time, they will become weakened because there will be much pressure built up in here. That's like in a way that the tricuspid valve cannot hold again. And you can, with time, you will see weakening of the tricuspid valve, and that is when you auscultate, you need to hear some gallops and murmurs and all those things. They are mostly from valves, right? All right, so that is what happens in right ventricular hypertrophy, and as a result, it also causes cyanosis, like we talked about. Then O, remember we are going according to the proof, right? PROV B. Of course, the E is part of the V, so PROV. So now the O is overriding iota. Overriding iota. So when we say something is overriding, what does it mean? Look at this. Look at this iota. It's like it's already overriding. Okay. When we say something is overriding, it's like it's lying on something, right? But naturally, the iota overrides on the left ventricle. Pay attention to this very well. Naturally, okay, naturally the iota itself is lying or it's overriding on the left ventricle. So look at this picture very well. You see that the aorta, when you look at where it's coming from, oh my God, sorry. When you look at where it's coming from, you see that it's connected to the left ventricle. So it means it's receiving blood directly from here, from the left ventricle, then sending it to all parts of the body. Okay, that is with normal anatomy. But when it comes to overriding aorta, that's what happens. You will have the aorta line on both the left and the right ventricles. So what it means is that it will be receiving blood from the right ventricle, which mostly contains deoxygenated blood, and it will also be receiving blood from the left side, the left ventricle, which contains oxygenated blood. So it will have a mixture of both. Okay, so that's the meaning of overriding aorta. Okay, so the aorta overrides both ventricles instead of overriding on only the left ventricle as a normal, as a normal feature. Okay, it overrides on both ventricles. So you have blood from the right ventricle also entering the aorta, going into the systemic circulation, and you have oxygenated blood to all mixing. So that's what happens in overriding aorta, and it causes cyanosis. All right. Felix want to ask.
Good evening. Please, it's not Felix, it's Doris, but I'm using somebody's phone. My phone went dead. That's why. My simple question is, if I
Yo, Madam Felix, Doris, let's hear you.
can so that I can appreciate it well. Thank you.
Oh, I didn't hear the question. No. Did someone hear
Please,
it?
I'm saying that if I can have a picture, a pictorial illustration of the overriding aorta, so that I can appreciate it well, because I'm at the diagram. I can't really picture how it looks like. So if I can have a picture of it. Thank you.
Let me see. Okay, let me see. I don't want to miss the picture I'm using for illustration. Let me see if I can get another one here. Overriding. Okay, I think we have it here. Let's see. Okay. And look at my images. Okay, let's use this one. Okay, maybe this one too. I'm seeing. Let me see if I can. But are you looking at the pictures?
Yes, please.
That's the one I click. They are sending me. I want to use this one. Yeah. Yes, I think it's now in here. Now look at this one. Let me zoom out so that we can see it well. Oh, it's even small. Okay, so look at this picture. The one here, where I'm shaking the mouse. Are we seeing the aorta?
Yes, please.
So it's kind of like positioned somewhere in the middle, okay, of the heart. So blood from the left ventricle will be entering, blood from the right ventricle will be entering. So it lies on both of them, and there is opening. And they will all, blood will pass through here and enter. Blood will pass through here and enter. Okay.
Okay.
Yeah. Compare that one to this one, what we were looking at. You see, for this one, the aorta is only for our normal anatomy. You see, the aorta is only coming from the left ventricle, which is normal. But for this one, overriding aorta, you see where the aorta is. So it's kind of shifting itself from the left side to position itself in the middle so that it can receive blood from both.
Okay. Well understood. Thank you very much.
Yeah, so that is
What
what
causes it?
it's a congenital defect, like people are born
Okay.
with it.
Okay.
Yes. So it is not the mother's fault, it's not the child's fault, like the congenital heart disease. So they normally require surgery for correction. Okay. All right. So I think that one is also cleared. What is our next one? We've looked at P, we've looked at R, right? We've looked at O right now. We are left with the last thing to talk about. Then I think we can end here. So the V is the ventricular septal defect. So with the ventricular septal defect, now look at this diagram. This is your septum, right? That is the thick muscle layer, or let's say a muscle layer that divides the heart into two equal parts longitudinally. Okay, something like that. So when you have ventricular septal defect, what it means is that there is a hole between these two ventricles. Let me pick up my pen here. So ventricular septal. So this one the left ventricle. Let me write. This is the left ventricle. This is the right ventricle, right? And this is the septum. This muscle layer you see is the septum. So there's a hole connecting them. Okay, that's what we call ventricular septal defect. So there's a defect in the septum. The septum is this muscle layer, cardiac muscle layer separating the two ventricles. So when you have a hole between them, then that is what happens in ventricular septal defect. And you have blood flowing from the right side to the left side. Okay. Normally, I know I don't know what someone is thinking, but I'm sure someone might be thinking that because the pressure on the left side is higher than the right side, blood should be coming to the right side more than blood should be going to the left side. Is that someone's question? But if it's someone's question, at the end of the day, deoxygenated blood will mix with oxygenated blood. And what will be? It means most blood which are coming, okay, will bypass going through the pulmonary artery to the lungs for oxygenation. That's what it means. It means most of the blood that will come will find its way to shift into the left ventricle. Then it will be pumped throughout the entire circulation. So that will also lead to what? Cyanosis. So the proof, okay, prove that you have what? The Tetralogy of fallot. AROV, then you can make it small so that you know that it's ventricular septal defect. So pulmonary stenosis, right ventricular hypertrophy, overriding aorta, and ventricular septal defect. So prove that you have what? Tetralogy of fallot, right? So there is something we call tet spells among people who have Tetralogy of fallot. Okay, I intentionally added these names so that when you see hypoxic spell or hypercyanotic spell, you wouldn't think of something different. It's the same as that spell. Okay. So what happens in this test spell is that test spells happens to those with tetralogy of fallot. When they encounter any of these things, they can That's why we call it what hypercyanotic or hypoxic spell. So they easily turn bluish. The whole skin will be turning blue, showing you how serious their body is lacking what oxygen. Okay. Yeah. So crying can exacerbate or can start a third spell. Sorry, a third spell. Okay. Feeding. Sometimes just feeding alone. Do you know that because the heart is already struggling? Okay. So they even feel tired when they are eating. I mean, they feel like it's a pressure when they are eating. And that alone can also even bring about the third spell, okay, among them. And stress. Generally, the stress level, I mean, stressors in general, even regardless of tetralogy or fallot, stress is not good, right? So anything stressful on children with tetralogy of fallot can get death spells. So how do you see it? That is what we're written here. You see cyanosis, you see them having difficulty breathing, okay, and hypoxemia. So cyanosis, dyspnea, and hypoxemia. Any question here or any addition? Okay. Now, how do you manage test spells? You do need to chest position. So over here, you see, we are saying that's the first action you have to do. So when you get questions, always take your time. You already know things about test spell, right? So when the question is before you, take your time to analyze. The answer might be looking at you. The answer might be staring at you. Take your time and pick uh, anyone that matters, especially with regards to test spells. I can't give you example right now. I think I have plenty examples to give you. Questions. I have plenty questions to give you ahead. Okay, so just prepare. And oxygen therapy, at least just to support, right? Calm environment, and you can give morphine too. So look at this. You can get a test spell question and get all of these options available. So that's why some people will be like, on the NCLES, it's like all the options are correct, okay? All the options seems to be correct. So someone will be like, so which one should I choose for me to be mad? There is always a priority, or there's always prioritization that you need to do for your answers. You can get all options correct over there, but with let's say with regards to what is happening in the question, you have to choose only one. That is what it means. Okay. So when you get all these four options, nature's position is your first. Okay. Do you know why? Who can tell me how morphine helps in these people? Hello? No one is answering.
It decreases the demand that it decreases the demand of the heart muscle seeking for O2.
Yes. So let me ask you one question and let's see if we can link it. Let's say for adults, in congestive cardiac failure, is it advisable or is it allowed to give morphine? Hello?
Yes, sir. Yes, it's advisable.
Okay. So if you don't know it today, okay? And why are you saying yes? Like what happens?
Sir, please, I think the other time we established that it reduces preload, so it
Yes.
reduces pressure on the heart. Helps
Yes.
with eating.
Yes. Yes. Exactly. Exactly the answer. Okay. All right. Someone will ask, what is preload? You should know preload and afterload. You can write it somewhere. Okay. After class, you can read about it. All right. Thank you anyway. So morphine. So it's like in a similar way. Okay. Morphine helps to relax the heart muscles. Please, not in a way that will send you into respiratory depression. No. So if you are thinking of maybe morphine can worsen the situation by sending the patient um, very low, because morphine is a downer, right? Morphine can have sedative effect and all of that. Please, it's not like that. Okay, morphine have different functions when it comes to I mean, even though it can control the heart, the pain, okay, it can control your pain and everything, but it also helps you to relax. It relaxes the heart muscles, slows down increase respiratory rate and all of that. All right. So that's how you manage it in simple terms. Now, how to prevent it? How do you prevent that spells? The first time you are saying keep infants calm. Okay, you should get a conducive environment for them so that they can get calm. Then another one is swaddling. So this one, let's say when you get case study questions, I think, sorry, select all that apply questions rather. Okay, when you get select all that apply questions, you should be able to know them. Who knows swaddling? No one. When you wrap up a baby, okay, all over, so you can type swaddling somewhere. When you wipe up a baby, sorry, when you wrap up a baby, then like the baby looks as if he or she is in the womb, like as in that same position as he or she would be if she was in her mother's womb. Okay. So that is swaddling. The use of pacifiers too can help sometimes, help divert the attention to what is happening. Then small but frequent foods. Please feed them in bits. Okay? Feed them in bits, but multiple times. So don't try and do your breakfast, lunch, and supper. If you are someone who does only breakfast and supper, don't do that to them, okay? So they can be eating small, 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 like throughout the day. Okay. And I think small but frequent meals helps with almost all conditions that you won't stay MPU, right? All right. So that is the little I can tell you about third spells and the tetralogy of fallot. Sorry, if you have any question, you can ask. Any question?
Sergi, please, I have a question.
Okay.
Please, with the position, is then the knee chest only for infants? Because I know for older children it's squatting. So, or I think knee chest is similar to squatting. Anyway, I want to ask knee chest for infants and for older children.
Squatting. Who knows about that?
Yeah, squatting for older children.
Okay. Okay.
It's not still the knee chest because like when they are squatting, it's like their knee is closer.
Their
Then they are
knees. Okay.
the infants are smaller,
The
so
infant,
you
yeah, okay. Yeah, you can carry on, yeah. So wait. I understand what our brother and our sister are saying. When you have, let's say, a baby below 1 year, most of them cannot even stand alone. Okay, so those people they can't squat. So what maybe you can do to help is to make sure that you bend them or you position them in a way that their knees are drawn closer to their chest. Okay, so that is knee chest. But if the person can squat, at the end of the day, the knee gets to the heart, right? Or it gets to the chest, doesn't it? So whether you position the patient, especially if they can't stand, like a one below 1 year old, if they can't stand alone or they can't squat or they can't position themselves, you can, I mean, try and position them that way. But for someone who is, let's say, a toddler, okay, late toddlers or maybe school, I don't even want to go there. But if the person can squat, at the end of the day, you still have the knees closer to the chest, so it's the same thing. Yeah, so knee chest position, okay, knee chest position, so that is it. All right.
Yes, please.
Come again.
I said I have a question.
Okay, you can ask your question.
Yeah. Please, about the position the knee to chest. Please, I want to understand what it does. What is the rationale? How is it going to help them? Is it going to help them breathe better or just to take some rest? Like I remember when I was doing NMC exam, I got something like this that children with Tetralogy of fallot, when they are playing, they squat. So they were asking what the squatting will help them do. So if you can explain, that will be okay.
Okay, so you want to know how the squatting helps to um give them a relief? That's your question, right?
Yes, the squatting and this knee to chest.
The knee chest, yes. So whether it's squatting or knee chest, the same thing. At the end of the day, you have your chest. I mean, you have your knee closer to your chest. Okay, so that is it.
Okay.
So I think it in all, what it does is to reduce or to prevent. I think you can't say outright prevention, but it helps to reduce the shunting of the blood from the right side to the left side of the heart. Okay. Let me see if I can explain in layman terms. When you see when you have a third spell, you are cyanotic, you are bluish you are bluish all over. You are bluish because the blood circulating through your body is not receiving oxygen enough. When the blood gets to the right side of the heart, it's not going to the lungs for oxygenation. It's just shifting to the left side of the heart and it enters into systemic circulation right away. Okay, that is what is happening. So when you assume that position, it helps to reduce the amount of blood which is moving from the right side of that. Remember, they have issues with the heart, and there's already in their normal state, there's blood moving from the right to the left side of the heart already. Okay, without going to the lungs for oxygenation. So where the knee chest position is a way that helps to prevent or reduce. Let me say, I want to use my words carefully. It helps to reduce the shunting or the movement of blood from the right side of the heart to the left side of the heart. Okay. There is one I think there is more explanation to it how it does that. Okay. I think it's about pressure difference. It's about pressure difference. When you bend down, the pressure from below your inferior vena cava, okay, there is like a pressure decrease. right? And when there's a pressure decrease, I think there's decreased venous returns too. When you bend down, movement of blood from your lower part to upper part of the body is a bit slowed, isn't it?
Yeah.
Yes. So I think that in a way helps to ensure that a lot of blood is not moving from the right side of the heart to to the left side of that. Because if everything should come to your heart directly, it will still move to the left side of the heart and enter back into the circulatory system. And you'll be bluish all over. So I think that is one part to help reduce the shunting. And I think the position itself to help in relaxing. Okay, it helps to relax them in that situation. That is what I can say. I don't know if someone has a deeper explanation to it. The person can share with us. Anyone? Or we should take this one. Okay. Any other question?
Listen,
Yes, Sister Aduma.
listen. And please, concerning the positioning, I would want to strike the difference between the position. With the niches, they are saying that it's for infants and the squatting is for older child.
Yeah.
And again, I read that we can use a beta blocker, that is propranolol, for their treatment, their management.
For test spells.
Yes.
No,
They are saying it prevents
beta
future
blockers are not
spells.
for death spell. So the beta blockers are
Oh,
not
I read
specifically
it
for that.
that they are saying. I read it that it prevents future spells. They are used to prevent future spells.
Oh, okay. Okay, that is also new to me anyway. Okay. All right. It's good we are reading plenty. Okay, but English trick. Okay. Generally, when you get questions and they want solutions, let your drug option be your last. Okay. Let drug options be your last. If there are better options like positional changes, something that you need to do, normally. So it's like, you see, those of you who track the EKG classes that we did, we will try, if you want to correct a bad heart rhythm, we'll try some other means, right? Like the bigger stimulation and all of that before we come to drugs. Okay, so it's some things run through everything on NCLEX. If you have, let's say, a patient who is short of breath, the patient has pneumonia, and the patient is having shortness of breath, what would be your priority action? One,
Raise the
give
head.
or self-prescribed antibiotics. Okay. Two, give oxygen. Three, give IV fluids. Giving antibiotics is 100% true. Giving oxygen is 100% true. If there's option like raise head end of bed, that would be your priority thing to do right now. Because the question said, even though the patient has pneumonia, but it's telling you that the question is trying to explain to you that currently patient is having shortness of breath. So what can you do to solve that issue in that diagnosis? So that is one trick. Sometimes how to get entrance questions correct. Okay. So always look at the problem happening in the whole show. Then go for answers that solve those things. Right. So when it comes to, we are stressing on this, I don't think anyone will forget about the nature's position being the first thing to do in test scores. I don't think anyone here will ever forget. So I wanted to show you the images just in case. So you see this one is, so any position, so even for an adult, you can lie on your side and bring your knees closer to your chest. So this is the squatting, moves your knee closer to your chest, whether lying on your side or squatting or being held, especially for the case, okay, being held in such manner. They are all knee chest positions. Are we okay? All right. Can we continue? Any other question? Okay. All right. Oh, sorry. Now we are coming to talk about another thing, atrial septal defect. Okay. Atrial septal defect. So when it comes to atrial septal defect, what it means is that, listen to the name. So this is a whole condition altogether, okay? Remember, we've done tetralogy of fallot. We've looked at all the four things in them. This is a separate issue, okay? Normally, it doesn't cause cyanosis, all right? Even though you have issues happening, but it doesn't cause cyanosis. So it happens when you have an opening between the two atria, okay? When you have an opening between the two atria, and you can have blood moving from the left to the right, okay, left to right shunting. So if it happened to be like right to left shunting, then that would be a cyanotic one. So when you have blood moving from the left side of the left side of the heart contains oxygenated blood. When it moves from there to the right side, you are not likely to show signs of cyanosis, right? Okay. And what is the key finding? The key finding is heart murmur. Okay. The key finding is heart murmur. And you have a fixed split S2. Who understands this term? Who knows fixed split S2? You know the sound, right? You know the heart sounds? Fixed split S2 heart sound. What is the normal heart sound that we have, like every normal person?
Lambda.
S1.
So S1 is and S2. S1 is the lab and S2 is. Okay, so when you have a phase split S2, what does it mean? So you see, normally, when you hear the lab, which is S1, what happens when there is S1? Who can tell us? I want us to pick it up from there. Oh, I think we knew all of these things before, right? When you hear lab, what does it mean? What valves are opening? Or what does it mean? Or what is filling?
The ventricles.
No. The
Except when
atrium.
the atrioventricular valve
The atrium.
closes. That is when you hear the S1 sound.
Mm-hmm.
Okay. So let us listen to this one. Okay. The normal heart sound is S1 and S2. Okay. The S1 is the one that we assume to be the lab, right? So that is the first sound that is heard at the beginning of what? a systole. When we say at the beginning of a systole, what does it mean?
The heart's contracting.
The heart contracting. Good. You know where the mitral valve is, right? The mitral valve is at the left side of the heart. So what happens is that when you have the lap means that the mitral valve is closing, and when the mitral valve is closed, and I think let me see if I can use this diagram to show you. We are entering into deep things, right? So let us see. Let me use this one. Okay, just imagine this is a normal heart, right? The mitral valve is here. It's the same as the bicuspid valve. So this, let me pick up my pen. This is the atrium. This is the ventricle, and you have the mitral valve here. Okay. So what it means is that over here, the mitral valve is here. So what we are saying is that the S1 heart sound, which is the lap sound that we normally hear, it's heard at the beginning of what? A systole. And as sister said, systole is what? Contraction. So before the ventricles can contract and eject blood out of it, this valve has to close so that the pressure will build up here and push the blood out so that you don't have backflow of blood getting to the left atrium again. Okay. Similar thing is happening here anyway. All right. So that is how the lab sound. Sorry, yes, that's how the lab sound is. Identified. What about the dab sound, which is the S2 sound? What is the meaning of diastole?
Is it the diastolic?
What is the meaning of the diastole?
Sir, please, we can't hear you. Did you say diastole?
Like we have a systole and we have a diastole, like diastolic as in diastole.
That's in diastolic.
Good. So
Uh-huh.
systole is when your blood, when your heart contracts. Diastole is what? When your heart relaxes, right? So good. So S2 sounds, right? You hear S2 heart sounds when there's a diastole. Okay. Normally at the end of when the systole is ending and you have the diastole setting in. Okay. So I don't know how to make this thing simple for you to understand, but I'm trying my best anyway. S1 is the lab, okay, which means the heart is contracting. So as the heart pushes blood out of the ventricles, okay, the mitral valve has to close. And that is how come you hear that sound lab. And the dab is when the blood has ejected. Okay. It's when the blood has ejected. So when the blood is ejected, at the end of it, that's why we say at the end of the systole and at the beginning of the diastole. So at the end of the systole, that's after the blood has ejected and the heart is resting, which is at the beginning of what the diastole. That is where you will hear that sound. And that sound is normally produced by the aortic. So I'm drawing you right from here so that you can understand the split S2 sounds. Okay. So the S2 sound is heard from two valves, the pulmonary and the, or let me say pulmonic, okay, and the aortic valves. This is the how should I even say pulmonic, right? Or let's say pulmonary valve, pulmonary artery. This is what is going to the lungs for oxygenation from the left side of from the right side of the heart. Okay. And we have some too. I think we have pulmonary we have pulmonary vein too. Those wait. Arteries and veins, which one has valves? Veins rather, right? Veins have valves, right? Hello?
Yes.
Yes.
Are we confused?
No,
Veins
veins
Yeah,
have
I'm
have
valves.
not.
valves.
Arteries do not have valves, right? Good. So
Yes.
good. So let me use this one to demonstrate. I think this one will make sense rather. So the S1 sound, which is that one we've established it, is the sound produced when there is systole, and the sound is heard when the mitral valve closes. That's the valve at the left side of the heart, dividing uh, the left atrium from the right ventricle. From what am I saying? Dividing the left ventricle from the left atrium, rather. That's where you have the mitral valve, and that's how you hear the S1. So S1 is coming from mitral valve. In simple put, S2 is coming from two different valves. Okay, and that's what I'm trying to show you. One is from the pulmonary, whether pulmonary or pulmonic, however you say it. Okay, and the aortic valve. Okay, so the S2 sound is heard from this side when it is closing. Okay, when they are closing. You know, all the sounds are heard when there is closure of the valves, okay, not the opening. So S1 is heard when there is closure of the mitral valve, which is on the left side, okay, and the S2 is heard when there is closure, okay, that is after contraction and there's relaxation. The pulmonary valve and the aortic valve, they close, and that is what gives us the what S2 sound. Please, with this explanation, do you understand what I've just said before I even come to the split one? Hello? Do you understand what I just said?
Yes, please, I
Yes, please.
understand.
Okay. Yes. So what we are saying here, okay, if you understand this one, what we are saying here, let me come back to this one. Someone should mute up for us, please. So what we are saying here, okay, look at this one. I'm trying very hard to explain this one for you to understand. So what we are saying here as fixed split, please, this one is the main way you use to diagnose atrial septal defect. That's why I've taken my time. I want to just let you to understand. So this is how you diagnose it, okay? And there will be a heart murmur too. But this is one key thing. All right. So this is what happens. After understanding that the S1 is produced by the mitral valve when it closes, and the S2 is produced by two valves, that's the pulmonic and aortic valves. They do that together. Okay, that is they synchronize. When you say they synchronize, it means they communicate and close together. All right. When there is miscommunication, or in other words, asynchrony, okay, when there's miscommunication, or let's say asynchrony in them, like what it means is that all of them are closing at different times. That is what we call fixed split S2. So it's not like it will occur temporarily. Okay, it's like a fixed one. So anytime you hear an S2 sound, you hear them like you hear two different sounds distinctively. Okay, so the S2 sound normally is produced by two different valves. That's the pulmonary artery, pulmonary valve and the aortic valve. They do it together. But when there is atrial septal defect, how you realize it's atrial septal defect will split, because the one coming from the aortic valve is not synchronizing with the one coming from what? The pulmonary valve. I think for now it's a bit clear, isn't it? Or I should still come again?
Sir,
Yes.
sir, please, does that mean you will hear two S2 separately when you are checking it?
Yes, you
Since they
hear
don't
you hear well, I wish I listen to how it sounds, but you will not hear it as one as the normal dub. Okay, you hear two different sounds, but actually, like in your case, I don't know how it's going to sound. You know, we have other hard sounds like S3 and those things too. Okay, we have to be. I mean, you just have to be careful. It's not just an S3 sound or something. But for exam's sake, okay, what I would say is that they always bring this for you. Like you have the, I mean, the S2 sound splitting. All right, you have S2 sound splitting. So what I would advise is just take note of the split S2 sound, right? And when we say something is split, it means there are two. I mean, you hear it in two. You not hear it all together. So yes, but curiously, I don't know how that will sound. Anyway,
Okay.
yes, but it will definitely be two. They will split. Any other question?
So the reason I was
So
asking was because of the fixed, and they said split.
Yeah. So it will always be two. Yes, for that one, it will always be two. Do you know what I'm thinking? You see, as you're asking your questions, I'm also asking myself some questions over here in my head. You see, I brought in S3 sound. So I was like, if it's split, and let's say there's an abnormality. I don't know if it's someone's question. I don't know. If let's say it's split and there's an abnormality, let's say an extra S3, how can you differentiate it from the splitted one? It's not a nice question. So
yes,
so
so
yes, it's a nice question. I'm also asking myself a lot of questions. But for exam's sake, you know, for this one, they are not going to give you sounds for you to just play and listen. No. Just have it in mind that in atrial septal defect, you will have a splitted S2. And the reason, if you should go into details, the reason why you're having the splitted S2 sounds is what we've thought about. Okay, the S2 sounds should produce all at once when there is closure of the aortic valve and the pulmonary valve. I always say, no, whether pulmonic or pulmonary valve is the same thing. Right? So when there's asynchrony, they don't communicate together and they all want to close at different times. You hear two different sounds. Okay. And that is it's a fixed one. Unless the atrial septal defect has been corrected before everything can come back to normal. But as long as it's there, you're going to have the fixed split S2. Any addition?
really,
Any
so
question?
I want to ask. So the heart murmur itself is it from the contraction of the left ventricles, and how does it sound like? I don't know if I don't, like, how do you distinct is that this is a heart murmur different from the normal lap dap?
A nice question. So normally, when you hear murmurs are different from the normal. So murmurs are abnormal sounds. Okay, look at the sound lab and dab. They are well pronounced. Okay. When murmurs are like it's like you have, should I say, a liquid moving through a certain vacuum, producing some kind of like they normally use this swishing, like swishing or whooshing sound, okay, to differentiate it. Okay, it's like you have just imagine having a fluid moving through, let's say, a vacuum or something like that. Okay, in that whooshing manner. So you always hear a murmur to be like a whooshing sound. I wish I can search here and play for you to hear. Well, I don't know.
Like,
So like whooshing.
oh,
Okay. So I don't know. Yes, you have your phones, right? If you have your phones, you can type mama sound, and you hear that sound. Like it's different from the lab and that. Okay, so you hear it's like a liquid, or let's say a fluid rushing through a vacuum, like that whooshing sound, something like that. So it's very different and distinct from the normal S1 and S2. Who has
So
found
yeah, I
that?
have. Can
Who
I
has
play?
found out? I don't know whether I can play it here.
Can I play?
Okay, play
Okay.
it here and let's see. Mhm.
Okay. So you,
I
no,
don't
no,
know
no.
if
I'm
someone.
using my phone.
Okay, huh? Do it and let's see.
Okay.
Splitting, you'll have to listen over the pulmonic region. If you hear splitting in other areas, this suggests a loud P2 and can be seen in certain disease states such as pulmonary hypertension and atrial septal defects. Here's a patient from Stanford Hospital
You want to
who
get just the
volunteered to
sound.
let us record his heart sounds.
Yeah, it's coming.
Take a listen.
Okay, good. So I think we hear the tutor aspect, but I think do you hear, those of you who are listening carefully? Do you hear that, like that is like a
Yeah.
turbulence?
Yes, I did.
Yeah. Yes.
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 Turbulence.
So
Yeah.
that one makes it the mama. Okay. That one makes it a mama. So it's like you have a fluid rushing through a certain vacuum, like whoosh, that sound. Okay. So normally they use the English word whooshing. Okay, or maybe sometimes either whooshing or swishing. That sound to this differentiate it.
swooshing.
Yeah, for me, I like the whooshing because it goes like whoo, something like that. You know that. Uh-huh. So it's different. Okay, it's different from the lab dab. So whenever you auscultate patients' heart and you are listening for S1, S2, and any abnormality, it's always over here, and I think like not over here, as part of our normal nursing assessment, it should be part. Okay. So that when there is any abnormal heart sound aside from the lab dab that you hear, which are actual heartbeats, if you hear of any other murmurs, you have to report. Any other question before we carry on? Okay. All right.
Hello,
And
sir.
yeah, let me just something, I'm coming on. Something
Hello,
just came
sir.
into my mind.
Okay.
Write this thing down. I think I remember there's another sound called gallop sound, right? Gallop sound are also normally abnormal sounds. Okay. Write it somewhere and you can play it and listen to how that one also sounds. Okay. It's not a normal sound. Our normal sounds are S1, S2. Mammals, gallops, and I think there might be even more of them. They are all abnormalities. You can play them around and look at how they sound. Yes, sister. Your question.
Hello.
Yes.
Please, I had a question and they were asking about the positions to listen to this sound. So please, can you help us with some of the positions?
The
Where
position
to
that
examine, yeah, where you can examine to listen to all these sounds. The part of I think the chest and the back, the exact place to listen to the sound.
okay, so not in regard to septal defect, like atrial septal defect.
No.
Oh, I think
No.
this one, like
She's
any
referring
position,
to the auscultation point.
auscultation of the for this one, I think any position that exposes it's all on your anterior part of your chest, right? So whether you are sitting or you are lying down, so like sitting up or maybe supine, lying down is supine, right, on your back. Any of this is correct because you
No,
remember.
sir. Not
Come
that.
again.
They needed exact parts of the body, like where to listen to S1, like they will mention a specific part of the chest, and I don't know if you understand it.
Are you talking about the one with Ebb's point, like aortic, pulmonic, Ebb's
Yes,
point?
yes. That's
Oh,
what
so,
she's referring to.
oh, okay. So not like the position that you should be in when we are checking for it.
No.
Oh, okay. Listen, I think it's even in your notes. Can someone drop a picture of it in the masterclass page? Or if not, after class, I will drop a picture. Okay, there are positions on the heart. Okay, I think if I remember very well, the aortic valve is like there's a tricky way of even remembering it. If I remember, I'll just write it and add it up. Sometimes it's confusing. You have to. Do you know when I started this, it was confusing me with EKG lead placement. You know how those of you who know how to do EKG, so it got to a time it was confusing me. Where you can determine the aortic space, where to auscultate for it, the pulmonic, and the pulmonic and the others, right? So that is a different thing. I will drop it, or maybe someone will drop it on the page, okay? And maybe we shall add a trick to it so that you can remember. All right. Any other question?
Hello.
Yes.
Please, I wanted to share my experience with the galloping of the heart, the sound.
Okay.
So I had an opportunity to listen to that of a patient, and it's similar to that of a horse galloping. You can hear two sounds at a time, like gugum, like I say, a horse is galloping. It's similar to that sound.
Oh, okay.
Yeah. So I asked, and the doctor said because it makes a similar sound to that of a horse galloping. So that was how they had the name, something
The
like that.
name.
It's been
Okay.
years, so I've forgotten.
Okay.
That's what I wanted to talk about.
Did
Thank
you
you
say
very much.
gugum?
I
Sorry.
don't know. Leave him, okay? You need to go and listen to yours and come and tell us what you hear. Yeah, so it's like I think gallop is just an English word, right? It's not a medical term. So like when horse gallops, you know, that sound like she said, okay. So that's how come so you can, if you want to listen to how it is, it's different from mammals, right? So they are also abnormal sounds. So please, the lab that you see, you hear lab that like normally, okay. Any heart sound aside that, it could be the beginning of an abnormality of the heart. Please don't forget our main key point here, okay? Like what we are saying, you will have what a split S2 sound for atrial septal defect. All right, let's look at this one too. So today we couldn't look at my questions, right? I have plenty of questions for you on all of these things. Well, we'll see.
We will do it.
Okay. Um, you know, questions, some questions can enter into a lot of questions, and it's a whole, sometimes anatomy has to come in and all of that, you know, it's a big topic. But I couldn't go into details because any nurse or midwife here has treated this before in nursing school, right? So sometimes when I'm preparing notes, my main focus is to fish out what you can be asked on the end case. Okay, not just like anatomy and physiology of the whole thing, right? Otherwise, we can learn. You know that atrial septal defect. If you want to learn even this one alone, it's a big thing, right? If you have a note on that, you can just check. It's a whole big thing, but because the things are plenty, I try to squeeze and search for salient ones that will matter more on the ankles. So when I try to tell you stress on something, like when I try to stress on something that take notes, at least for ankles, right? Yeah, so that is it. Then let's look at coarctation of the aorta. What is happening here? When we say
Boss,
coarctation, yes.
please, does it mean this one you don't have any like physical signs and symptoms apart from the one that you the nurse will listen for?
Oh, there are signs and symptoms. I think there is difficulty. I mean, there is dyspnea. What can I say? What can I tell you? I think those heart conditions they have similar signs and symptoms. Let me see if I can get specific ones. Can someone help us?
We have it. We have it more in cardiology. So
Yeah, but if someone can help us with some, we can be grateful. Like about 5 of them. I know you have difficulty breathing. That one for all heart condition, it's there. Okay.
Is
And
fatigue part?
yes, fatigue is part. You have fatigue, yes.
Is it a
For all heart
septal
condition.
defect?
Yes.
Yes.
She's asking about signs and symptoms of this one. Okay.
So the
So
first
any
is,
please,
yeah.
please listen to this. Fatigue, fatigue, dyspnea, what else? I think palpitations too. These three things, if I remember, they run through about 90% of them.
There will be cyanosis
Okay.
too.
Boss said
For
no, sir.
atrial defect, there's no cyanosis. That one, so that's one tricky part of it. Okay. Take note, there is no cyanosis in atrial defect.
I
I
think there will
Tetralogy
know
of
also
they
fallot,
be
call
there is
the
cyanosis.
stages. They
Is
call
there
it
So when we check, we
cyanosis?
added
pain.
it.
Is someone saying there is cyanosis?
No,
I
I
said
said I
when
know
I
they
checked.
call these conditions the pink babies, and they call the tetralogy of fallot the blue baby.
The blue what? Babies.
The blue babies, yes, and they call
Okay,
these
oh, yeah,
cases the pink cases.
yeah, yeah, yeah. All right. So,
Seb, I'm confused though.
like I said,
Please, oh, hello, sir. I'm confused though. In the physiology,
yes.
when there's a septal defect, but there will be a mix-up of the oxygenated and deoxygenated. So the blood that will go into circulation will be, as in less, will be less. There will be less oxygen in that blood. So why did you say there's no cyanosis? Or maybe I'm missing the point.
Okay, okay. So let me tell you something. If you have a pen, you can write it somewhere. I think when
Okay,
I was
okay.
doing my research, I wanted to even include it in my slide, but I couldn't get time. But I wrote it somewhere. So we have I think Marquis had a nice way of also differentiating it. So with the congenital heart diseases, we have the cyanotic one and the cyanotic ones. Okay. Cyanotic ones are the ones that you see the bluish discoloration. All right. And acyanotic is the one that you are not likely to see. And the reason is that let me tell you one key difference in it so that you understand. With the cyanotic one, you have deoxygenated blood which is entering into the systemic circulation. I'm repeating myself here. Kindly listen to this part well. With the cyanotic congenital heart diseases, okay, I'll give you examples anyway. The main thing is that you have deoxygenated blood, which is entering into the systemic circulation so that it will still go around. So just imagine blood without oxygen still going around, you will turn bluish. But with the acyanotic ones, you have oxygenated blood rather coming into the lungs, okay, or maybe coming into the right side. So it's like you have part of the deoxygenated blood mixing the oxygenated blood rather, but you will see. How should I even make it simple for you to understand this? It's more of left to right shunt, okay? When we say left to right shunt, the left side of the heart is more oxygenated per anatomy, and I hope everybody understands this. So with the acyanotic one, the one that you don't turn bluish, you have oxygenated blood recirculating sometimes, especially to the lungs, okay? You might have a small mixture of deoxygenated blood though, but you have more of the oxygenated blood like coming back. You see, normally when blood is oxygenated, it should continue to go through systemic circulation. But in the acyanotic heart defect, what happens is that the blood which is already rich in oxygen, they tend to go back to the lung again. So it's like it's getting its double, okay? Even though it's normal, so it's abnormal, even though it's getting oxygen again, like over and over, but it's abnormal. Whenever the blood goes to the lungs for oxygen, it should, get out of the body through the aorta, then give oxygen to all parts of the body. But this one, it keeps on going, like the circular manner, and you might have some deoxygenated blood also mixing, but you have more of the oxygenated blood. That is why you don't turn bluish. So the oxygenated blood tends to cover the effects of the small deoxygenated blood mixing. I don't know if you understand it. I've tried to explain it in simple terms.
Me, I'm still confused because the defect is there. I am thinking there will still be a mix up of the oxygenated and deoxygenated. So
wait, I'll give you an example. But just follow what I'm trying to say. Like follow my words and maybe you will understand. Okay. Let me use this picture. Then maybe I'll ask you a direct question. Then maybe you will understand. Look at this picture. Let me pick my pen. When you have blood from this right side, okay, moving to the left side here, what do you think will happen? So, in terms of oxygen concentration of the blood here, right from the left side here, it enters into systemic circulation, right? So when you have blood moving from the right side to the left side, what do you think will happen?
Low oxygenation.
You see, it will reduce the oxygen levels of the blood which is already here, which is oxygenated here, and definitely the patient will turn blue. This is in the case of an example is ventricular septal defect. Okay, in ventricular septal defect, you have a hole here, but how the condition is, it's not, even though the hole is here. I know, maybe I know what you are trying to think.
Oh,
But
say
if
I
there's a
get you
hole,
now. So I get you now. So
blood.
sorry, I was
Mhm.
mixing it up with the ventricular septal defect. Sorry, I was mixing it up with the ventricular septal defect. So I get you now.
Oh, okay. I I hope you get me though.
Yeah,
But
yeah, yeah.
this
I
is
was
ventricular
mixing up.
septal defect, okay? Like with,
Okay.
do you know it's different thing happening in atrial septal defect? That one, the defect is in the atrium. And do you know what is happening?
In the ventricular.
No, I'm talking about atrial septal defect. Do you know what is happening in there?
No, no.
So this one too, it's similar to the ventricular septal defect. Still, it's septum. Okay, there's a hole in the septum. But this one in the upper chambers, which is in the atrium. But because of, I don't know, maybe there might be other deep reasons, but because of the morphology or maybe the structure of the heart, in atrial septal defect, you have more of the blood moving from the left to the right side rather than from the right to the left. I'm repeating myself. In atrial septal defect, you have blood moving from the left side, okay, to the right side, okay, more than right side to the left. And in ventricular septal defect, you have blood moving from the right side of the heart more to the left side. So if I understand, or maybe if I should try and explain, what I will say is that you see the pressures down here. If I should use the pressures to like maybe someone will say the pressures at the left side will also be equal to the right side. So why is it that still it's able to push its way through to the left side? But that's how it happens for ventricular septal defect. As for atrial septal defect, you have oxygenated blood moving from here to here. So what I wanted to say is that in cyanotic congenital heart diseases, you have blood shunting from the right side of the heart to the left side. Okay, that is what happens normally when you have cyanotic, or let's say congenital heart disease that will tend to cyanosis, so that will end up you getting blue. Then when we come to the acyanotic congenital heart diseases, what happens is that you have blood moving from the left side of the heart to the right side. Okay. And you don't become blue or you don't turn cyanotic because at the end of the day, you know that it's oxygenated blood which is coming to the left side, right? And it will still come or it will still force its way through the pulmonary artery and go for some extent of oxygen again. So it's like even though the blood coming from the left side of the heart, let me clean this one. I think it's a mess already here. So already the blood coming from here to here is already oxygenated, right? It mixes with the deoxygenated blood here. But at the end of the day, this whole thing will still pass through the pulmonary artery and go for some oxygen before it comes back to the heart. So some will be pumped into systemic circulation, but most of them will just jump here and like I told you, they will revisit the lungs again for oxygen, and like the cycle will be continuous. Even though some will escape through the aorta then get to all parts of the body. So that is how normally acyanotic congenital heart diseases normally work. With the cyanotic one, you have blood shunting from the right side rather to the left side. And when anything gets to the left side, it enters through the aorta, then goes through systemic circulation directly. That is how come you see the evidence, or the let me see the evidence of the bluish color you see. Do you understand what I'm saying? Or it is not well understood? Do you understand?
Yes, it's understood. So if I'm getting you right, there's in the ASD there's left to right shunt. So with that one, oxygenated blood enters circulation. That's why they don't get the cyanosis.
Yes.
Okay.
And the oxygenated blood that comes to even to the right side of that, they all go to the lungs again for some additional oxygen. Okay, that is why they don't. So the low level of oxygen that happens or that is in the blood is not enough to cause your whole body to turn blue. But you see, the one that is coming from the right directly into the left side, it enters into the same systemic circulation, and already it is not rich in oxygen. So you have like deoxygenated blood circulating throughout the whole body, and that is how come you get the bluish discoloration. Understood?
Yes.
Okay. So I was trying to give you an example, okay, like what I was trying to. So I think with explanation it's fine. Let me just give you examples and we can go. Tetralogy of Fallot is an example of the cyanotic. Okay, we thought about that. And another one is I've not captured it here, but you can write it down. Transposition of the great arteries. It's another anatomy thing to describe what is happening. Okay, but you can write it somewhere. So normally they call it I think four T's, right? The T's. Okay, there's another one, tricuspid atresia. Okay, tricuspid atresia. It's also there. Then pulmonary venous return is also part, like they are there. All right. I think the commonest ones are the tetralogy of Fallot, the transposition of the great arteries, and tricuspid atresia. These are the commonest ones that you are likely to see cyanosis throughout. And acyanotic ones are atrial septal defect, ventricular septal defect. So you see this one, it has been ventricular septal defect, even though it is part of what is happening in the trilogy of Fallot, right? But wait, is there ventricular septal defect in the tetralogy of Fallot?
Yes, yes.
Are you sure?
Yeah, that is your view.
Yes, sir.
We have it.
Yes.
The probe
It's part.
is
Okay.
part.
Good. 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 It's part. Okay. So when you mention tetralogy of Fallot, okay, I want us to draw a certain line here. When you mention tetralogy of Fallot, it's four conditions all combined, right? But ventricular septal defect alone can be separated. If that one alone is mentioned, because you have mixed blood, like as in atrial septal defect, that one alone cannot cause you cyanosis. So let us take note of that. Okay. Normally, ventricular septal defect and pulmonary stenosis and like this right ventricular hypertrophy, they normally confuse me. Like they normally have become very big in my mind. So I was just trying to connect. So please, the atrial septal defect, I'm saying it again. The septal conditions, okay, the atrial septal defect and the ventricular septal defect. Ventricular septal defect, being part of the tetralogy of Fallot, can be singled out as a cyanotic one. But when you just mention tetralogy of Fallot, it's everything. So tetralogy of Fallot is cyanotic congenital heart disease. Do you understand the statement that I just made? When you see any question and maybe they want to ask which of the following is cyanotic congenital heart disease, and you see any of the septal defects, whether ventricular septal defects or atrial septal defects, because the blood is mixing, it will not cause cyanosis. Okay, are we there? So you can. It's a bit. I think that is very exceptional about that. So you can write it down so that I mean you don't miss that. Okay. All right. Then
Please, please, I didn't get you well. When you're trying to
so
explain.
what I'm saying is that ventricular septal defect, it's part of the tetralogy of Fallot, right? It's part of the four things happening.
Yes.
When you hear
Yes.
tetralogy of Fallot, like it's a bundle, okay? It's a four bundle, like it's made up of four things. Generally, it's a cyanotic congenital heart disease. But when ventricular septal defect is singled out alone, it is acyanotic.
Oh, okay. Oh, okay.
Oh, but
You
why?
get it?
Well, I don't understand why about here.
Yes.
Please,
And
I don't understand why it
and
should
and
be
the why
cyanotic.
is
Yeah, please. I
so the
don't
why
understand why.
I'm asking the why
No, continue.
okay, maybe network delays. Okay, so the why of the matter is that you have both oxygenated blood and deoxygenated blood mixing up. Okay, so the oxygenated blood is able to is able to like overshadow some of the the deoxygenated blood, and you don't see that pronounced like bluish discoloration. Okay, so it's like you have oxygenated blood, deoxygenated blood mixing up. Okay, so it's like the blood is not too deoxygenated in a way that it will cause cyanosis. It's a tricky one, and that is one exceptional one. Okay, so um you can find out. I don't know how you are taking it, but it's an
Say,
exceptional one.
please,
You
but
can
will
write it
their
somewhere.
SPO2 be low? The SPO2 will it be low?
It's likely to be low, yes. And of course, they will
Okay.
have this fatigue, they will have dyspnea, they will have all the signs, but just that it will not be too much for you to turn that bluish. Like um, other heart conditions, like let's say right ventricular hypertrophy. Right ventricular hypertrophy, you definitely go. As part of the trilogy of Fallot, you can actually be cyanotic, and like conditions like transposition of the great arteries, you will definitely turn blue because of what is happening. Okay, pulmonary stenosis, right? Pulmonary stenosis. Remember, the blood is not going to the lungs for oxygenation. Okay, the blood is not going to the lungs for oxygenation, so you are likely to turn blue for pulmonary stenosis. But for ventricular septal defect, you have oxygenated blood and deoxygenated blood mixing up. So the oxygenated blood tends to like overshadow the deoxygenated blood to prevent you from getting bluish, but you can still have those fatigue and oxygen issues. Are we there? Do you understand what I just said? It's a bit confusing, right? So
We get it.
try and write it somewhere so that it doesn't trick you. Okay. When ventricular septal defect is singled out alone, it is acyanotic, right? It means it doesn't cause bluish discoloration. But the whole bundle of the trilogy of Fallot causes cyanosis. All right. Then coarctation of the aorta. I think that was the next thing to talk about. We couldn't even get here. Wow.
Please, my hand is up.
And it's already okay. You can talk.
Okay, so please, my question is, does the four disorder, the tetralogy of fallot, happen at the same time?
Who can answer that simple question?
So I think maybe one leads to the other. Like the pulmonic stenosis like this, it can cause the right ventricular hypertrophy because when there's backflow of blood, it backs up in the right ventricle. And then as time goes on, it becomes big, it enlarges.
Okay, so I'm thinking this way. Why do we call it tetralogy of Fallot as a main condition? It means you have four things happening together, right? And yes, what our sister said is also true. Okay, so you have four things happening together. Maybe one can start and lead to the other, but before it can be called tetralogy of Fallot, you have to get all those four things happening before you can call it that. If it is only pulmonary stenosis happening, then it's pulmonary stenosis. If it's only right ventricular hypertrophy, then it is only right ventricular hypertrophy. But if you have all the four things happening, then we call it what? Tetralogy of Fallot. So yes, all should be happening. Okay.
Okay, so
That's the
this
answer.
clears my confusion with the atrial septal defect. So if these four are happening at the same time, then it means there will be cyanosis. But if it is just one, which is the atrial septal defect or the ventricular septal defect, let me say the ventricular septal defect, then it means it's acyanotic. Thank you.
Yeah. So you got a picture. Yeah, that is what you mean. Okay.
Yeah, all right. Thank you.
All right, you're welcome. Any other question? I think they are fitting into your time plenty. Because a lot of questions. Okay, so let us read about someone talking to us. Let us read more. Okay, yeah, you can talk to us. Oh, wait. Okay, you can talk. Go ahead.
I didn't get the response that you gave to the person who asked the question that do we have to see all the four conditions to warrant it as a tetralogy of Fallot? I think my line was breaking badly, so I didn't hear your response.
Okay, I said yes. And the reason I gave was that that's why it is called Tetralogy of Fallot. So if it's Tetralogy of Fallot, you should have all those four things happening. So it is yes, all should be happening together. Even though they may start from maybe one could lead to the other, or maybe there might be two. Okay, there might be two already there. Let me give you one example. You know that pulmonary stenosis can lead to right ventricular hypertrophy?
Yes, with the explanation you gave.
Yes. It can lead to yes. So it you can have maybe two starting or maybe one starting, but before it can be diagnosed and it can be labeled as tetralogy of Fallot, you should have all the four things happening.
Okay, thank you.
Yes. You are welcome. Any other question? I don't see any hand here.
Please, but so
Sure.
please, in a select order applies question because that's where my mind normally goes. If they mention the cyanotic conditions and they've mentioned all and they included ventricular septal defects without mentioning tetralogy of Fallot, so you shouldn't pick it. Is that what you are saying?
Those are the cyanotic.
Yeah.
Yeah, so don't pick ventricular septal defect alone as cyanotic congenital heart. defect. Okay.
Okay. Okay. Thank you.
Yeah. Any other question? All right.